All right.
Hi.
Hello, this is Nat
Hello.
Pandian here. And
Hello.
Good evening, India.
Hi. Hi.
hello, can you hear us? Can
I
you?
can hear you loud and clear. Can you hear us?
Yes, certainly. And I'm Nat Pandian here. And there is a big team of experts and a good audience. And I know some of you, but in any case, would you like to introduce yourself and give a little
Is
background?
I'd be happy to, Dr. Pandy, and it's nice to hear from you. Good evening, India. Good morning from Milwaukee. We are starting our TAVR case right now. I am Renu Jain. I'm a cardiologist who specializes in echocardiography, and I am a poor substitute for Dr. Khandheria, who unfortunately could not be with us this morning. I'd like to introduce the TAVR team as we start setting up. You'll see here Dr. O'Hare now getting access. Daniel O'Hare is a cardiac surgeon, and he's a director of our TAVR program. Right next to him is Tanvir Bajwa, who is an interventional cardiologist and another director of our TAVR program. As you see here, and I think I heard you speaking about this earlier, this is our entire TAVR team. So we meet very early once a week to talk about TAVR cases, and then all of us coordinate our schedules so that we're all here as part of a dedicated TAVR team. You'll see specialized technicians, specialists, specialized sonographers, as well as our cardiac anesthesiologist, Kirk Hansen over there. I don't know, Dr. Hansen, if you want to just say hello, who also is dedicated to the TAVR program in part. If it's all right, Dr. Pandian, I was going to show us loading the valves as we're getting set up. Does that sound good?
Definitely. You are doing great. And later,
thanks, Dr. Pandian.
while after the loading is done, you can give us a little background of the patient and why you chose core valve and what size you're planning and so forth.
Absolutely, that sounds great. So what we're seeing here right now, and I think the camera is focused on this. Do you guys see the core valve, the Evolut loading?
Yes, we do.
All right, perfect. So you can go ahead and start loading. Just talking to the assistant here. This patient we'll hear more about in a few minutes. But what we decided based on CT sizing, as well as all of us kind of meeting and reviewing the data, is a 29 Medtronic Evolut. And what you're seeing right now is the loading of that valve onto the delivery system that will then be presented to the cath lab table and then be placed in the patient. And you can see we here at St. Luke's do our own loading of the valve. We've just kind of gotten used to that. We've done about, I think, 1,000 TAVRs now in the last 5 years. The majority have been Medtronic core valve and Evolut. Although what is nice about being a big program is we've really had the ability to see lots of different valves loaded and lots of different valves placed in patients. So I think we're almost set now with the valve loading. And if you don't mind, I'm going to walk around and I'm going to introduce Dr. Arman Sheikh next. He is one of our interventional cardiology fellows. And what he will do is he will present to you the patient story.
Thank you. That
Dr.
sounds.
Sheikh?
Dr.
And
Sheikh,
Dr.
where
Pandy,
are you? No, I'm looking for Dr.
Dr.
Sheikh.
Sheikh, where are you?
Call the police.
Hello, hope everybody can hear me okay.
Yes, we can.
Excellent. Was just getting the radial access for the big catheter that we're going to use to take some pictures. So just some background on our patient today. He's a 69-year-old gentleman, has a history of aortic stenosis, severe aortic stenosis, as well as moderate mitral valve stenosis. His significant past medical history is with CAD as well as CABG in the past. Also has a history of PE, Hodgkin's lymphoma in the past, for which he had chest radiation, which obviously makes any kind of repeat open heart surgery a little bit more complex and high risk. And also is a relatively frail gentleman, especially for his age of 69. Next slide, please. So he came to see us with his chief symptom being severe shortness of breath, also fatigue, and really just a worsening of his overall activity tolerance. Just couldn't walk and do the things that he was able to do a few months ago. You see some of his echo findings there. An aortic valve area of only 0.86, mean gradient of almost 39, and a peak velocity of 4.2. His mitral valve findings there, which moderate to severe in that case, and also had some significant tricuspid regurgitation. He had a cardiac cath as part of his workup. He has significant native CAD, but his bypass grafts that had been done previously overall just had some mild disease and were overall patent. Next slide, please. So what you see here is just some of the pre-TAVR workup that we did, looking at both the annulus size, the sinuses of salvo measurements you see there, looking at the aortic arch and its main vessels, and then also the distal abdominal aorta and the iliacs. For that that's generally the axis we use, and you can see hopefully all the measurements there that met the criteria for this patient being able to get a TAVR. Next slide, please.
The measurements, okay, you're already going to show. I was going to ask you from CT rather than echo.
That's correct. Yeah, they do. These patients do get an echo prior as well, but the main measurements in terms of the access and the measurements for valve size and delivery are mostly done via CT, which you can see the measurements for this patient here. Excellent, excellent question. Can we go to the next slide again, please? And here you can see the more specific both annulus and sinus of Valsalva measurements that are made. A dedicated CT faculty that does these measurements for us in one of our main suites here at St. Luke's Hospital. I think now we are going to turn back over to Dr. Jane, and she's going to show some echo images.
Thank
you
you.
very much, Dr. Sheikh. You can go back to getting access. Any questions on your end before I move over to the echo images?
No, you all are doing great. We're just listening and learning.
So I am going to introduce you to Sarah Raymer, RDCS. She's one of our sonographers. As part of our TAVR team, we have 4 dedicated sonographers who really develop expertise in TAVR, and they're with us every day when we do TAVRs. We do about 6 to 10 a week here at St. Luke's. Sarah is going to just describe a little bit the views she got, what a difference a year makes. When we did this last year, we did this with a TEE. And since that, 12 months ago, I think I heard someone talking about it earlier, we have now basically changed entirely to doing TAVR with transthoracic. And so only very rarely in cases where the patient needs general anesthesia for some other indication will we end up doing a TEE. Here you go, Sarah.
Thank you. Good evening. Okay, so for the echo imaging, we start with the parasternal long axis here. Here is a good view. We like to look at LV function, rule out any pericardial effusion, take a brief look at the mitral valve. Here, LV function, a good look at the mitral valve, and then we take a good look at the valve. This is good to show where the calcium deposit is, and then we also look at the regurgitation as well if there's presence or absence of any AI that's there. We take a brief look at the mitral again, just for any regurgitation or stenosis. And then parasternal short axis view, we like to look at the leaflets, again, calcium deposit, where the regurgitation is, how much of it there is, and then as well as LV function and effusion. And then we go down to a brief apical picture to look at. This is a good image for LV RV function, rule out effusion. Again, take a look at the aortic valve the best that we can see, as well as the regurgitation. Sometimes we can see it down here better than the parasternal imaging or vice versa. And then same with mitral regurgitation. We check quick gradients, and then also take a brief look at the aortic valve in 3-dimensional view as well. All right, back to Dr. Jane here.
While you're coming on, it is a mitral valve or both valves, maybe radiation-induced valve disease. The annular calcium looks like involving more of an anterior valve, makes me wonder. I'm talking about the mitral valve, whether it's a radiation-induced. What is your thought?
Right. Great. thank you for inviting us into your meeting. This gentleman is highly symptomatic. His dyspnea with any sort of activity, and as you saw in the echo, has severe aortic stenosis and at least moderate mitral stenosis. So, we with previous radiation, previous surgery, thought that we ought to really try to focus on relieving his symptoms. And so today we are addressing his aortic stenosis, and whether or not he needs any further treatment for the mitral disease will really depend on how he does after this. But we think we'll get good symptom relief with addressing the aortic valve first. We are just kind of getting set up here. A couple of things. I don't know if you can see the field here. There are a couple of things going on. So in that we have access in the right radial artery with 6 French sheath and a pigtail catheter, which is positioned in the non-coronary cusp of the aortic valve from the radial approach.
Push a little. Get it off the wall.
Okay. And we have right femoral access with surgical exposure, the right common femoral artery, and then 14 French sheath in here through which we'll cross the valve, measure the hemodynamics, and eventually exchange for our wire. We usually use the Safari wire, which is a pre-curved wire, and we use that to deliver the valve. So right now we're just kind of getting the baseline hemodynamics. I don't know if we can show that.
Can you show the hemodynamics?
Yeah, yes.
You see?
Yeah.
So you'll notice there's a gradient. It's a little hard to see with the lights here, but a gradient in the range of 40 to 50 millimeters of mercury, and the LVEDP is low, less than 20, and so that's our starting point. And this gentleman's gradient, this is at rest, of course, and with any exertion, I'm quite certain is much higher.
Is it on?
So we're gonna put the Safari wire in now.
Yeah.
I can't hear him.
So
Ken, you wanna chat a little
this
bit?
guy was seen in the clinic and then came back to the hospital over the
I
weekend
can hear him.
with class 4 heart failure symptom. That's why we moved him up. So our plan is to do the aortic valve today and then reassess the mitral valve at a later time. And so we are positioning, we crossed with a M-Platz catheter and a straight glide. That's a wire system we use. And now we have this pre-shaped wire into the left ventricle, and we are going to do our balloon angio BAV with this patient. Let's have the balloon, please. Pardon me? Oh, let's look at that. Yes. Okay, then I'll hold it.
Sure. So this valve is the Evolute, which is sort of the second generation core valve. It's recapturable, repositionable, and we really like it for that reason. It gives a lot of security that we're getting. We can get just the deployment that we're seeking, but it needs to be examined under fluoroscopy to make sure it's properly loaded. So we're doing that now. Hang on, me.
Looks very good.
Perfect.
Okay, just take it out. So this is a very important step to make sure the valve is fine before you start doing the BAV in case you develop some acute AI. So this is a 22/4 balloon. I think we recommend that in a very calcified valve, we should do the BAV. That makes things a little bit easier for the valve to expand. All right, go ahead, Dr. Sheikh, go. Very nice. Down. You saw that we did not pace during the ballooning, which we don't like to do, especially with patients with poor ventricle. That could be very detrimental for that poor ventricle.
I have the wire.
Do you
Part of the original-
may I ask a question? Do you do a balloon valvuloplasty only in selected cases or almost every case?
So we were doing in every case, as part of the protocol, when we were doing, this is a commercial case, nowadays we only do with very calcified valves. So about 20 to 30% of the patient, they get valvuloplasty.
Okay.
And as part of the protocol, when we had TEE, transesophageal, we would check post-BAV for aortic regurgitation. Now in the transthoracic era, what we do is unless there's a clinical indication, we save our transthoracic images till after the valve is deployed. We move the radiation part of it out of the way as much as we can and just take images
Valve,
right at the
please.
end.
What is the ACT?
So,
We want to make sure the ACT above 250. Please keep us posted.
so this is a 14 French device. We took the 14 French sheath out. We're just going to go over the wire. It has an inline sheath, and so really just a 14 French hole in the vessel. And can you show us the arch, please? Thank you.
It's coming up there.
So we're in LAO 30, cranial 1. We're going to cross the valve, and that little marker on the end, we want to make sure that's nice and flat, just like it is. It looks good.
All right.
So we're going to come back. That's how we know the plane of the deployment. Looks like our pigtails moved a little bit.
I think it may be fine. We can just take a picture
Sure.
there. Good.
Okay, arm the injector, please. So we're going to take a root angiogram. That's fine.
Okay, let us know where it ends.
We're not
Okay, very
quite.
good. So we can.
Our pigtail is up just a little
Yeah,
bit.
so we are repositioning our pigtail into the, that's a very important marker in the non-coronary cusp. So this looks pretty good then right there now.
I think that's it.
Yes, I think that was it. This is it. One more picture here. Yes.
Much better.
All right, draw the line, please.
So we're in the non-coronary cusp, so that's an important point to confirm. We're going to use the pigtail as our marker for how deep to position the valve.
Dr.
Prior to
Bashwa, can you
deployment.
talk a little bit about drawing the line, what that means? I don't know if they can see it on the
Exactly.
screen.
Remember when we are doing this case, the pigtail in the non-coronary cusp is very important. We draw the line on the monitor after the aortic root shot to make sure we are going to end up with. The goal is 3 to 5 millimeter below the annulus. So that's what we draw it on the monitor. It's a very low-tech way, but that really helps us to position the valve where we want.
Kirk, can you stand by the pace for us?
Red line or blue line?
This is
Thank
the
you.
blue line here. And we have two markers, one marker on the monitor, the other one is a pigtail in the non-coronary cusp. All right, so I'm going to then start flaring up.
Yep.
So what they do is they draw a line on the fluoroscopy screen.
Right,
I think
right.
we're not able to show that to you there, but
Yeah.
it really sort of is their guide for how to manage the depth.
Right.
Up a little bit.
And now you see the valve deploying.
Pull back.
Let's get our.
There, it's starting to open.
We're going to get a picture here. Yeah, we're just flaring the valve. We're going to get a picture and confirm the depth. It looks like we're about 4 millimeters or so deep. So we're going to pace for a moment here. Kirk, can you pace for us at 120, please? Good. The pressure's down a little bit, and we're going to deploy.
Pacer off, please. Pacer back off, please.
So we'll check our depth here, which I think looks
Looks
fantastic.
very good. So if we can just talk about, so now at this time, we have, this valve is totally retrievable. We can recapture it if we are not very happy. And the valve is functioning, blood pressure is fine. So we are very happy with the depth. There is a calcium shelf going from the
We should probably
to the anterior mitral leaflet. So
just a little bit more here because we're 50.
we are happy with the depth, and we are going to start deploying it. All right, then I'm
Yep.
going to.
Yep. Give a little back here.
Yeah. A little bit further.
So the slow final deployment ensures that the valve stays right where we put it.
A little bit further. Pressure. The wire.
Wow, Dr. Bajwa, that's looking very, very nice.
Yeah.
I'm gonna
Oh.
head over to the echo area where we will shortly take a look at it by echo as well.
Sir,
Okay.
one question, sir. Whether they keep
Yeah,
the pigtail jailed? Like,
sorry.
pigtail kadito.
No. Yeah, the pigtail, we leave it there. We can pull it out. We'll show you. It really doesn't cause any problem. We are going to pull it out in front of you. Yes, go ahead with the sheet. That really does not. You can leave it there. You can pull out. Does not matter this particular valve as much. So then why don't we put this sheath and then you can pull the pigtail out.
Yep. Look at this. Go ahead.
Yeah. Let's have the pigtail, please. Was the ACT 250 and above?
We gave a couple.
Yeah. Good.
Now we're in the descending. So we're going to replace the pigtail into left ventricle and re-examine the hemodynamics.
Yeah. Wire out, please. Let's have the.
So in the old days of TE, this is where we would be looking on TE at the valve. Because this is a self-expandable valve, if we look on TEE now, we usually would come back in a few minutes as the valve expanded more and see that what paravalvular regurgitation we might see initially would be gone even within 5 or 10 minutes. As we're now in the transthoracic days, we usually wait for all of the hemodynamics and then start taking pictures, which we will start doing very, very shortly. How do the hemodynamics look, Dr. Bajwa?
Well, looking, EDP is below 20. There is no significant gradient. We are a little bit concerned about the diastolic separation. That's why we are going to see what the echo looks like.
And now
It's
it's
a calcified. We're going to.
time for echo. Part of the things that we were concerned about when we looked at this echo originally in our TAVR meeting was the significant calcium we presumed from radiation damage, as well as the LVOT calcium extending into the mitral. And so part of what we're looking on now on transthoracic is not only the depth of the valve, but also how expanded it is and whether there's any role for post-balloon dilating.
Christine?
So I think you can
We
see
have
on the
about
echo
24 or
here,
26
really
balloons
nice
available.
images on this patient. To me, Dr. Bajwa, the depth looks very good. I can see by, the sonographer tilting that there is some paravalvular regurgitation. And what we'll do now is we'll go to the short axis. Dr. Bajwa, you see the echo there? There's a short axis.
Very good. We are looking
And
at
there's some tissue Doppler interference, but there also is this paravalvular regurgitation jet at about 2 o'clock in that area where there was a lot of calcium.
it. Yeah.
Dr. Pandian, you see the echo very well. I
Yes,
imagine.
yes, and we can see the paravalvular leak also.
And then what we've really kind of worked on since we've started doing transthoracic echo is these para-apical views. We interrogate both in the 5-chamber, the 3-chamber to get different parts of the clock or the the entire short axis of that aortic valve. And here you can see very nicely that sonographer through a lot of tilting and scanning and adjustment is bringing out that paravalvular regurgitation. I think overall it's still mild. What is nice now about how we do TAVR here is we do it as a combination of what we see on echo and also the hemodynamics. I don't know, Dr. O'Hare, Dr. Bajwa, what your thoughts were.
That's what we are. So Dan, why don't we go ahead? Why don't you talk about how do we evaluate PVR? We are very satisfied, by the way, with the results. hemodynamics, if we can focus on those, are excellent. LV EDP is good, so then go ahead.
So we use three modalities. We use the root angiogram, the hemodynamics, and echo to make a final assessment. And usually all three are congruent. In this case, the hemodynamics look good. The EDP is low. The echo shows just a mild paravalvular leak, which we anticipated a little bit. We haven't done a root shot. I don't know, Tanvir, do you want to get a root shot here and
I
just
think
take
we
a
can.
quick look?
Sure,
Yeah.
sure.
So we'll get a quick root shot here. We got to get our pigtail back in.
This is the pigtail is right here.
If the
What's higher up?
if the iotography confirms the same amount of leak, are you going to do a post dilation or just going to accept this?
Probably. I think with just a mild leak and everything else looking okay, we would leave that. And what we know about these valves is that there's continued radial force, and generally by the day that's gone. I think it's somewhat related to the calcium that
Right.
that you
right.
saw on the imaging, and yeah, I think we expect a little bit of that.
Sure, and the balloon valvuloplasty post-procedure we usually do if we are not with the hemodynamics. If the LV EDP is still high, the gradient is high, then I think that gives us a pause to do something. Here, the LV EDP is really about 10 to 15, and we are really very happy with that.
Okay.
So we're going to get a quick
root shot.
for
Okay.
you here.
That should be fine. Are we ready?
And let's make the valve flat a little bit. Can you just go a little bit caudal first and see if we can?
Just lower down, please, the valve. We can then take this out.
Hard to see if that's getting better. I think that's a little better.
Yeah, go a little bit more caudal, a little bit less caudal. Go the other way. This is beautiful. Leave it right there. This is good. Show us lower part of the ventricle. So we should be fine.
Okay, so we're gonna. Are the injectors armed, ready to go? Valve is set. Okay, here we go. So again, I think what you see on the echo is there's a small leak. It's
Right.
immediately adjacent to that calcium block,
Right.
which fits with our echo. And I think in view of the fact that our diastolic pressure has come up quite a bit, we think it's mild on echo. Hemodynamics all look good. I think we're happy with this.
I
Okay.
think we sort of anticipated this.
Oh,
Right.
that
Right.
Given all of the we see in the LVOT calcium, we sort of anticipated there would be a small mild leak, and I think we've seen that patients have done very, very well. As the valve expands a little bit more, that leak may get a little bit less, but certainly it's not a leak that should impact.
Because one of the important consideration is when the calcium shelf going to the anterior mitral leaflet,
Right.
if you're too aggressive with the ballooning, the annular rupture. So here I think abundance of evidence we have from the EDP, from the other things. And with this particular valve, as you know, as the time goes on, it expands further. The mild leaks become trace or even disappear. So we are pretty happy with just watching it.
Excellent. Now,
Okay.
there will be some questions from our panelists or audience here. And it's a great
Please.
job, went smoothly. And definitely our friend, the interventional cardiologist, who is also a singer, will buy you all drinks tonight, right? All right. In the meantime, let me check with the panelists here whether they have any question.
Then we would like to know after how many days will this paravalvular leak disappear? If you think that the
Usually on the next day we'll do a transthoracic echo to just make sure everything is okay.
Oh.
And most of the time it's usually gone by then.
Okay, this patient has
So
aortic the mitral valve problem. What do you think you will be your approach to the mitral valve problem? The mitral valve.
Well, we talked a little bit about a couple of different options. Of course, one would be to balloon the valve, but I think this gentleman's got some component of mitral insufficiency already.
Okay.
with this stenosis. So that's one option. The other option that we have used in selected patients is to use the Sapien, Edwards Sapien E valve, which we invert on the delivery system and give it from deliver from a transapical approach into the mitral annulus. And we have, I think about 8 patients we've done this with very good results.
Oh.
It's a little unusual. There's usually some PVL, but we've had some remarkable results in symptom relief in patients with severe calcific native mitral stenosis.
Great.
Well,
So that's what our plan is.
as Nat was suggesting, is there a possibility that the mitral disease is post-radiation related? Because this patient has
I think
undergone.
that's certainly
Yeah,
that's certainly a possibility given the extensive calcification.
yeah, I
and
think that was sort of our impression when we looked at the echo, is that calcium from radiation at a young age sort of extends all throughout the aortic valve, through that LVOT, that mitral valve, aortic intravalvular fibrosa area, and then through the mitral valve. And so certainly when we looked at this echo, we were concerned that it was radiation. I know Dr. Bajwa, Dr. O'Hare, earlier on, I heard some talk about age, 99, 100 years old, being too old for TAVR. How did you guys approach the 69-year-old with radiation and giving him an option of surgery versus TAVR?
Right.
Okay,
Remember, I
okay.
think the first thing is that, as Dan mentioned, we have seen now here calcific mitral stenosis, which is very different than rheumatic disease, which we see in India and Southeast Asia. This type of patient we have, as Dan mentioned, about 12 cases we have done, where, remember, you cannot do the balloon valvuloplasty of the mitral valve because the leaflets are so calcified. So valve replacement is the issue, and we have done cases transapically with results because there's enough calcium to hold that valve, and this is Sapien XT. That's what our plan was. Do the aortic valve, see how much better he feels, and then we will take the incremental approach. The second question was
Age.
age. I mean, he's a young guy, but remember, in a STS score, from the cardiologist standpoint, we follow the STS score very closely. 1 to 3 is low risk, 4 to 8 is intermediate risk, 8 to 15 is high risk, and above 15 is the non-surgical or extreme risk. But in STS score, there are certain things which are not represented, like radiation injury, the aorta, which is very calcified, the lead pipe aorta. So this guy is relatively young and may not be STS score may not be as high, but the radiation to the chest really excludes him for any surgery. As a matter of fact, he was operated on by a surgeon at another institution who opened the chest. You can see and he just put the graft to the LAD and closed it because they thought they cannot do this case. So I think in STS score, certain things are not represented. That's the point I want to make, that when our surgeon sees a patient as a heart team, then based on patient's fragility, based on the radiation or the calcification of the aorta, although the STS score may be low, but they are not surgical candidates.
Yeah, great. They are all important points. And I guess in case, because unusual pathophysiologic scenario from the usual ones, supposing there's an early restenosis, you can always go back and put a valve in a valve, right?
Absolutely,
Right?
absolutely.
Yes.
Oh,
And the other thing I would just wanted to point out is we have, the system or the technique we use, we really try to minimize fluoroscopy exposure. So this patient's had 10 minutes of fluoro time and about 30, not more than 32 cc's of contrast. So it doesn't take a lot of time, effort, radiation, and just to deliver these valves. It can be done relatively quickly.
That's great, great.
okay. Any
other-
questions? Any other questions? Any
Anybody?
comments?
No, it's gone excellent, smooth
I think-
smooth manner.
I think
Oh,
we are all thoroughly impressed. I think it took only about 10 to 15 minutes to.
Every case looks this good.
We are
Yeah.
thoroughly impressed, and there is no gradient after the valve has been placed. Oh, it is fantastic, and from our side, let's give them a big hand.
Fantastic,
It's
great
fantastic.
job. Please do give my best to Bijoy, and
will.
because then we'll great, and thanks again. Fantastic show.
The whole we like to congratulate the whole team. Fantastic work. Fantastic.
Thank you.
Okay.
Thank you.
Thank
Good
you very
night.
much.
Time for a drink.
Good night. It's 8 in the morning here, but yes.